Good morning. We are waiting for folks to gather. We'll be standing by and we'll get going here in just a few minutes, about 3 minutes after the hour. Thank you, May. As she just shared in the chat, please make sure you're on mute. We are waiting for folks to gather. We've got two presentations today, Plan Data Feed and an update on the Encounter Data Improvement Project. We'll be starting with Plan Data Feed in about 3 minutes or so. So please stand by. Thank you. Hi, Elizabeth. Glad you're here. Again, for folks that are joining, we'll get started in about 2 to 3 minutes. We're just giving folks time to join. So please stand by. We'll be on shortly. All right, good morning, everybody. We're going to go ahead and get started with today's webinar. As always, it's sponsored by the good folks in the Program Data Reporting Division, part of the Enterprise Data Information Management Program. My name is Jeff Jennings. I am filling in for our usual hosts, Felicia and Alvin. They always do a bang-up job. I hope to do the same. I'm perhaps a bit technically challenged with this particular meeting software. We'll see, but I'll do my best. As usual, please put the questions in chat. Please make sure you're on mute. We will attempt to address questions if possible. Thank you, Kim. We'll attempt to address some questions if possible during the presentation or at the end of it during the questions period. But as often happens, we actually have to follow up to answer questions in depth. But we do make note of every question, and we do our best to follow up on each of those. So today we have 2 items on the agenda. Our main feature, plan data feed, which is an overview of the plan data feed data exchange. Kind of we've had it around for a couple of years. It's sort of a comprehensive data exchange and has been increasing in importance and focus, while at the same time the department is developing other methods of sharing large amounts of data about our valuable members. So, but today we'll look at plan data feed, kind of the pilot, if you will, in that sort of data sharing. And plan data feed was ably put together and implemented in large part by Jason Gentry. Jason's going to be doing the presenting today, and we'll have him come on in just a minute. I'm going to be driving the slideshow, and we'll go from there. So, as I mentioned, plan data feed is up first. The Encounter Data Improvement Project is up after that, and we'll get started. As I've gone over with questions and answers, I kind of covered that, but there it is in writing. And we do record this, and we post it to our SharePoint site and team site, which is available to all of our external trading partners. And now we will go with the presentation. So Jason, if you'd like, please go ahead, and I will drive the slideshows.
Great, thanks, Jeff. Welcome everybody, and I will try to stay on point and on topic, but as Jeff knows, when I get into the plan data feed at times I can run on a bit. Jeff, if you don't mind, next slide please.
All right.
All right, so what is the plan data feed? This is an outbound sharing of historical utilization data to our managed care plans. To our behavioral health plans, which includes the mental health plans, the integrated behavioral health plans that have started just this last year, our drug Medi-Cal organized delivery service plans, as well as our dental managed care. We're delivering the data from across the provider service platform. So the intent of the plan data feed is not to return data that a plan is sent to us, but rather to fill out the picture from across the Medi-Cal service platform. So, managed care plan being able to access or gain information, historical utilization on the mental health services that have been provided, or the dental services that have provided, etc. So it helps with also with some of the transition of members. The recipient population is restricted based on the plan's responsibility. So we, in keeping with HIPAA, we only deliver the data to which you have a relationship with a member. We're not just sending a blanket set of data out for everybody. All right. And it uses the all payer claims database, common data layout as a standard. And we're going to get into a little bit more detail on a lot of these items. Jeff, if you don't mind. So just real quick, a history of the plan data feed. It started way back in 2020. DHCS had received some complaints about some legacy files that were being used to share historical utilization to all of the counties or all of the plans, as well as with the CCI plans or counties. And there were it was designed, it was set up, it's one of those things where it was set up for a specific purpose way back in 2011, and then it was it grew organically without the rigor and structure that often is necessary to maintain a good relationship. So we kicked off this work group to address that, and at the same time, we had heard from our the behavioral health programs in the counties that they also would find benefit in having this historical utilization delivered to them, and so we combined the two. And so our work group kicked off 2020. We started our MS Teams plan data feed in 2021. Actually went live in January of 2022 for the managed care plans. We also, that's when we delivered the PDF analysis guide. We went live with mental health plans in June of 2022. We sunsetted the legacy files, some of them, and we'll get into that in a moment. Also in 2022, since then we've added TARS. We've added the drug Medi-Cal program plans. We have upgraded the standard from the standard version. We've added Medicare fee-for-service Part A and B and D, and actually there's a current effort to bring on Part C as well for fee-for-service. For the counties, we've added a finder file error check. We'll go over that a little bit, but I don't believe, SUDS data was added in November of last year. And then we did provide some SUDS clarification because the rules had changed, or some of the rules have changed. And so we had to provide additional clarification on how and who could use that data. Next slide, please. So I'm not going to read out all of the files. There were a number of legacy files that was started in 2011, as I mentioned, grew over time until we implemented and discontinued some of them in July of 2022. The thing I want to point out, and I believe you're going to get this this presentation, is if anybody is asking for these files, that is not a plan data feed file. They are files owned through your managed care plan or managed care coordinator. You would talk to them. If you're looking for any of those files, all right. We did not, there were some of the files that were CCI specific that we did not initially discontinue in July of 2022. I don't know because I don't own these. I don't know if they're still being delivered. I don't believe they are. However, the data that is contained within them is being delivered in the plan data feed. Next slide, please. So a little bit about the work group. Kicked off in 2022. We wanted to redefine the data exchange. We wanted to improve our fields, our data, and our processes. We wanted to add the mental health plans as recipients. The work group consisted of DHCS, managed care plan representatives, county mental health plan representatives, and CBHDA. We went through and developed our guiding principles. We developed the business requirements and the rules. We standardized on a structure. Instead of using the legacy 35C structure that DHCS had generated way back in 1979 or 78 or 80 or whatever, we actually went to a national standard, okay? We also wanted to improve the process and the communications. All right, next slide, please. So some of the lessons learned as we talked to the work groups, we even did a survey at one point, is we needed to improve our communications. Often the managed care plans were in the dark as to when files were going to be available. It was not consistent. You know, sometimes it would be, it could be months before a file was actually made available to the plan. We needed to improve our data literacy. So we were providing file structures and general field definitions, but not necessarily a good, clear understanding of what the data was or how it is. And that's obviously, you know, data literacy is something that happens over, you know, improves over time. So I wouldn't say we've got it all nailed down yet, but we have taken steps to improving that. Okay. Reference data.
Oh, sorry.
All right. We
Pretty
found
fingers.
that, yeah, not a problem. Reference data came to the realization that the reference data that is produced and owned by DHCS had not been updated to the plans in over a decade. But the reference data itself had been updated. So we needed to address that, as well as a lot of the national reference codes, you know, so diagnosis code. We were delivering the description along with the code, which didn't make a lot of sense because you all can look it up. and it was bloating our files, right? So we went ahead and cut all of that extraneous information out of the plan data feed. So those are some of the lessons learned. Next slide, please. So a little overview. Plan data feed's objectives: deliver a data exchange of historical utilization on a monthly basis that's standard across the board. Improve this exchange structure and processes to address some of those concerns and those lessons learned. We came up with 4 guiding principles for this project. We wanted to leverage standards. We wanted to mitigate and minimize data inconsistencies, improve our documentation, and reduce duplication. So those were the guiding principles for moving forward with the plan data feed. Next slide. Okay. So our solution, we decided to leverage the all payers claims database common data layout. That's a standardized historical utilization. It standardizes our historical utilization generated by DHCS. At the same time we were doing the plan data feed, there was also the all payers claims database being developed by who is now HCAI. Sorry, the chat got me confused, but I'm not hitting that yet. Standardize the data and incorporate additional data elements that have been requested by the plans. We wanted a defined timing by improving our processes. So instead of whenever we have it ready, it's ready on this date, and if it's not, we're going to communicate out. We wanted to improve our communication, so we went ahead and did some online tools. That's where the Microsoft Teams plan data feed, Microsoft Team is at, as well as we have a mailbox plan data feed at dhcs.ca.gov. We wanted to improve the understanding, so we developed an analysis guide. So it goes beyond just the data elements, name and description, or title and description, general description. It gets a little bit more in detail, and then improve our guidance and processes for reference data set updates. One of the things I do want to mention, the APCD-CDL is not the plan data feed, nor is the plan data feed the APCD-CDL. Okay, I often hear those confused. The All Payers Claims Database is a data structure, very similar to the X12, right? The plan data feed is our title for that exchange between the plans and DHCS. All right, next slide, please. So the APCD-CDL, it's a pipe delimited flat file. It consists of layouts for the header, trailer of every one of the files. It has an eligibility file. We do not include that in the plan data feed because we're focused on the historical utilization of services, not eligibility. It has a medical file, pharmacy and dental. The provider file contains additional information or details about the providers that were represented or identified in the medical, pharmacy, or dental files. The APCD-CDL, when we first started, it had some pretty strict restrictions under the copyright. It has since been opened up. It can be shared openly. However, I will say that you still need to, before you use it outside of the public, the Medi-Cal support space, you validate that it's not restricted under a commercial license. All right. And there is a supplemental file for the data fields that aren't carried on the APCD-CDL. So DHCS still has fields or data that we generated. It's our legacy data that we still want to provide. We want to stay as close to the standard that's defined under the common data layout as possible. And so instead of trying to shoehorn these special fields into it, we just created a supplemental file. It's a pretty basic general file. All right, next slide, please. Real quick, the file layout. This screenshot is actually from the errata, the APCD-CDL 3.0.1 errata. It defines the data element number, the name, the type and max length, a description with codes and sources where you're going to get it. This is not generated by DHCS. We do not own this file. We did not create the file. This is from the APCD CDL or APCD Council, All Payers Claims Database Council. They also, where there is a reference to or a likeness to one of the other standards, they've placed it in there. Okay. One of the things I want to note, I mentioned it before, APCD CDL is a pipe delimited flat file. Therefore, it does not enforce the field specifications. It does not enforce type, and it doesn't enforce max length. Those are there so that when you are putting it in your data set, you know how to structure your data set for this and what to expect. We do check to make sure that we do not exceed, when we generate the file, we do not exceed those values, but there's nothing inherent in the structure or in the creation of a pipe delimited file that would enforce it. All right, next slide. I hope I said that correctly. So what do we use the PDF for? It serves as a supplemental file that plans can use for monitoring the population's performance, analysis, and generating reports. It helps with your gaining historical utilization for transfer. So you have an individual that moves from Shasta down to LA. How do you get that history on that individual? Used for care coordination is not recommended except in the most limited fashion. So the one I just described, but that data is going to be old. There is data lag. DHCS is at the end of the process, right? So it could take, depending on the type of claim, it could take a year before we've even approved the claim, and then it'll hit the plan data feed. All right, so next slide, please. So some of the restrictions, some assumption that has been made is we are only doing paid claims and approved encounters. We are not delivering denied claims. We're not delivering rejected claims or denied or rejected encounters, etc. Only paid and approved. Some of the constraints that we're working under, since it's the only claim and encounter data, it will be time lagged. I mentioned that a moment ago. Some of it's some of it's as quick as only 2 weeks. Generally pharmacy, because we are close to real time in pharmacy. But a lot of when we get into our specialty mental health or our SUDS claims, and you're looking at a much greater lag time. Some of the data sets aren't available. Medi-Cal pays for a lot of different programs, especially in specialty programs such as the BCCTP. If the data is not in the DHCS data warehouse, it is not in the plan data feed. Our data warehouse is our source of truth for delivering data. Gaps in our source data are not addressed in the plan data feed. What that means is if you identify a gap, first step we do is check, is there an error with the way we have generated the plan data feed? Note that plan data feed is an automated programmed solution. It generates every single month the exact same way. It goes through the same process, it's the same steps and everything like that. But we will double check. We're the people that created the program are human, so we double check and make sure that that's the data that's in the data warehouse. If it's in the data warehouse, then it becomes a problem where it's likely coming from the source system in that fashion. While we will alert them, the responsibility of the plan data feed team is not we're not responsible for tracking it down and getting it solved, right? That's the source system and the programs involved that are responsible for that. Next slide, please. Member population. So this slide is basically telling you how do we determine what members we're going to send data to each one of the types of plans. So managed care plans, we use the member eligibility at the beginning of the month. That goes for the Medi-Cal dental plans as well. For our behavioral health plans, so the integrated behavioral health or mental health or drug Medi-Cal plans, we use a finder file. So those plans need to end up sending us a finder file that says, I have a service relationship with these individuals, please send me the data. That's basically what it is. Next slide, please. Some of the rules around the data that's being sent: 12 months of data is being sent based on the date of service. We did recognize early on that there are claims or encounters that are adjudicated that might be a year older or more than a year old, but have recently been adjudicated. So we've gone ahead and said anything that was adjudicated in the last month will be sent. 2 years of active medical fee-for-service TARS. Also, the only data that recipient doesn't already have. So if you're plan 68, with the plan code of 68, we are not going to send encounters that came from plan code 68 back to that recipient. Okay, so we want to only send the data that you as a plan have not generated and sent to DHCS. For managed care plans, we have taken a Delta file model whereby the first time the individual is with the plan, we send you 12 months. The following month, if they're still on the plan, we will only send you what's new. Okay. Now, this is a rudimentary logic, so we don't maintain whether or not what data you have received in the past. We use that eligibility. We look current month, are they in? Great. Last month, were they in? Yes, send a Delta. Or last month they were not in, we're sending you 12 months. Now, for those members that bounce in and out of Medi-Cal, so let's say October they're in, November they're not, December they're in, you're going to get 12 months in October, then you're going to get 12 months again in December, because we looked in December, we looked back, they weren't a member in November. Okay. Medicare fee-for-service opt-in required. So if you are wanting Medicare fee-for-service claims, there are requirements for opting into that to receive that. It is not automatic, right? The TARS, it's important to know, because TARS, treatment authorization requests, otherwise known as prior authorizations, they don't take a linear path from submission to approval, payment, and closeout. They can be anywhere at any point. They can skip steps in an hour. They can and so what we have found after doing our due analysis is that to give a sequential order of data on a monthly data feed would not work. So the way that TARS work is we receive it from the source system every week, and every week it's 2 years of active TARS, and it overwrites the prior upload to our data warehouse, so that we do not get a confused warehouse of anyhow. It would be very confusing if we tried to keep a history of all of those uploads. So we do overwrite the table in the warehouse. So when you receive it, you are receiving what's active as of that run. Okay, next slide, please. This is a little idea of how the data flows. So off to the left, we have our dental fee-for-service. This is the source systems that are feeding into the DHCS data warehouse. We use that as our source system for the plan data feed, using our target managed care plan and dental managed care plan members out of eligibility or the finder files for the behavioral health. That defines the plan data feed. That is then loaded to the DHCS SFTP server, and a recipient will then go and pull it. We do not push the data. We load it to the server, and it is up to the plans to go and retrieve it. The server rules, I believe, are 45 days. So once it lands on the server, you have 45 days to pick it up before it's deleted. Okay, next slide, please.
Yeah, and if I may, on this next slide, it's just something we put in to spell out some of the acronyms. We'll probably add a bit more to that before we post the presentation, but we're going to move on to the next slide.
Which is another slide of acronyms.
Yeah. Oh, yeah, you're right. That's right. So many acronyms.
Yes.
So,
yeah.
why don't we go to the
All right.
analysis
So
guide?
PDF and analysis guide. This is, to be honest, this is one of my most exciting moments when we developed this. Okay. Uh, One of the things I noted in the legacy files and in a lot of the data dictionaries that we've shared in the past is that you might get a data element number, you get a data element name and a description, and the name might be just a name. It'll be provider type, and in the description it'll say provider type. Well, that's not necessarily helpful. And what we found is the there are nuances in the data, especially when you can consolidate data from multiple sources, right? And so as questions started coming in, I started documenting it in this analysis guide. So for example, if you were to go on the medical file to diagnosis, you would find out that we have documented in there that what the claim types are that don't have a diagnosis on them. Okay. We have in here a description of provider, in our analysis guide, there's a description of provider type and when you get that and when you don't and why. It's a lot of good information. It's not everything about every field. Okay. I will say that. What it is not is does not replace the APCD-CDL errata. So you need to use this in conjunction with the APCD-CDL, not in lieu of or in replacement of the APCD-CDL. You need them side by side. You need to work with them together. We also did a map to the legacy files. We will likely be dropping that in the next year, just due to the fact that those legacy files have been closed down for years. So I don't see a reason to maintain that. So next slide, please. So some of the process highlights. Remember, I mentioned, we wanted to improve our processes. So we're on a monthly plan data feed. We have a set delivery schedule. It is the third Monday of the month, unless it's a holiday, in which case it's the third Tuesday of the month. In hindsight, I would probably do the third Friday of the month or third Wednesday of the month just to make life easier on me, but we didn't. And I'm not going to change it now. Plans obtain the reference data details from the reference data set owner. So for example, if you want provider taxonomy descriptions, you go to CMS. If it is something that DHCS owns and manages and has delivered, such as provider type, which is a coded reference data set, we will deliver that. And we deliver it on a monthly basis. Every month we give you the new reference data. Something to note on the reference data though, is it is an overwrite, right? We do not maintain history on our reference data in our data warehouse. Okay. One thing I really want to make sure everybody is clear of, the plan data feed is a scheduled monthly delivery. It is not an ad hoc service. We are not set up to take in requests for the plan data feed and deliver based on individual plan or county needs. Next slide, please. So the monthly process looks a little bit like our behavioral health plans need to load their Finder file by the 10th of each month, close the business. One business day after that, we run a job to verify the Finder files. The third Monday of the month, we post the files, unless it's a holiday, like I said, and then in which case it might be the third Tuesday of the month. And then you have 45 days from the time they're posted to when they get deleted. Next slide, please. The reference data map. So I have on our MS Teams, we have a reference data map that will identify what the reference data is and where you should go to get it. So it will state things like the plan is responsible for reviewing or retrieving and loading this information for diagnosis or for procedure codes. We're talking HCPCS, CPTs, etc. Again, if it's a DHCS source reference data, it is a part of the plan data feed monthly files that we send. Next slide. Outbound communications was the other thing we tried to improve on. So we did create the DHCS plan data feed Microsoft team. Plans have guest access. This is not a public site. You do have to request access. So if you don't have it, you need to contact the plan data feed at dhcs.ca.gov, and we will grant you access. Okay. We currently have about 400 members and guests. We put up updates, clarifications, responses. All these files I've talked about, along with others, are up there on the Microsoft team. We have a frequently asked questions section, and we upload the status each month of the file. In particular, if we're experiencing a problem, which has only happened, Jeff, what, once, twice in 3 years, 4 years, we will post it and say there is a problem, we're aware of it, etc. We also send direct emails to known participants for our behavioral health plans because we have collected that information, and we do coordinated messaging through MCOD and BH County support mailboxes and the periodic or meetings that they have. So I think MCOD holds a weekly and county support holds a monthly meeting. So when we have an outbound communication that needs to be sent out, that's how we go about it. Next slide, please. Inbound communications, you've heard me mention it a few times in this presentation. Plan data feed at dhcs.ca.gov is a mailbox. It's for incoming questions. I highly recommend going to our plan data feed Microsoft team posts first. It is quite extensive, the amount of information that we have posted in the Microsoft team. Next slide, please. So what are your responsibilities as a participant? All of the plans need to apply and maintain a license for the APCD-CDL. This has changed a little bit. I don't think you have to apply anymore, but you need to be aware of your responsibilities and how and when you can use it. That is not something that we have done. We do not have a blanket license for everybody. We are following their licensing model. You need to prepare your data repositories for the PDF. Unless you're a new plan, you've done this. You need to request SFTP PDF folder access if you don't have it already. You need to request access to the MS Teams that I just spoke about. And you have to retrieve the files within 45 days. If you do not, if we go back to my comment before, we're not an ad hoc service. You come to me us DHCS 3 months later and say, hey, I don't have this file. Can I get that? We cannot commit to being able to support you in that request. On occasion, we have been able to, but it is not a guarantee. For our behavioral health plans in the counties, there is a responsibility to create and submit a finder file no later than the 10th of the month that follows all of the instructions for that finder file. And then DHCS is responsible for monitoring and ensuring the data releases are current. So our approval to be able to deliver the data and to generate and post the PDF data sets. Next slide, please. Some of the form requirements. So there are some forms, depending on what you're after. Vendor access authorization letter. So if you have a third-party vendor that you have a business associates agreement with, and you want them to have direct access to DHCS to retrieve your plan data feed on the SFTP server, there is an authorization letter that is required. I know with the managed care plans in general, there are staff that pull down the data every month, and this isn't a problem. With our county behavioral health plans, this is a lot more common. Medicare data custodian forms. If you want the Medicare fee-for-service data, you need to have a data custodian form on file. It's needed for all of Medicare fee-for-service data. Now, if you want Part C, which is coming, it's not there yet, but there is going to be a conflict of interest or no conflict of interest letter that has to be completed. And with the Part D, there is a conflict of interest. So you're either going to send a letter that says, have a conflict of interest and how you have mitigated that conflict, or you don't have a conflict of interest. But that is a CMS requirement before we're able to release the Medicare fee-for-service data. Next slide, please. some of the periodic activities that we perform with the plan data feed, there is an annual data release. So we have an internal process. This is not something that any of the plans are required to participate in or provide information on. It's something internal to DHCS, but it is mandatory for us in order before we can release data to the server for you to pick up. We try to stay on top and ahead of these things. On occasion, there might be delays due to one reason or another. We have been pretty good at this, and it's yeah. So the biannual third-party vendor access that's that vendor letter I was mentioning. We try to keep that on a scheduled access. So right now, the current one is from July 2024 to June 2026. Come next year, summer of next year, we're going to be needing new letters back from anybody that has that third-party vendor authorization. Next slide, please. PDF lessons learned. All right, just some real quick high ones. Our claims control number is not unique. All right, so because we bring information from multiple systems, and some of those systems are replicated from, so for example, the CAMUS fee for service system is also the same system that's used in other sources. Well, that means that the code for claims control number is exactly the same. And we have found that it results when you consolidate all of these data sources, it's not unique. So in order to have a unique identifier, we did modify the one field for claim ID on the plan data feed or the CDL to have the first 20 characters of a claim ID and 15 characters for the data warehouse record ID. That way we are able to link you to the supplemental data file. And it provides that unique key. MS Teams allow for external collaboration. It's been great, and it's been replicated in other areas since then. And then our data release approval standardization. So one of the reasons the managed care plans were inconsistent in being able to retrieve data from DHCS prior to the plan data feed is that the data release would slow things down and they would back up. We have standardized how we go about it. And that has allowed us to be a lot more consistent in our delivery of the data. Next slide, please. Oh, thank you. We're at the questions period.
And actually, Jason, I'd like to add something if it's okay, because yes, it's myself and my team that support the plan data feed mailbox. And to be honest, folks, we have run into some resource constraints. We know that our response time is fairly slow. We are working on dedicating resources. Plan data feed has turned out to be very popular and to have engendered a lot of fairly complex questions about the data itself. Another thing I'll touch on is the FTP accounts. We serve as liaisons, and the teams that actually create and maintain the accounts are separate. So sometimes the timing there is a bit challenging, but I just want to acknowledge that we are aware that it takes us a while to respond to emails in that box. We're doing our best to improve that, and we'll continue it. So just wanted to let you know about that and acknowledge it. Thank you. Go ahead, Jason, if you have anything.
No, so we are almost out of time here, Jeff, and I didn't realize that it's going to spend that much time talking. And you still have another topic?
Yeah,
and a number of questions that were posted. So how do you want to handle it?
I think what we'll do, if it's okay with everybody, is do our usual follow-up where we circulate the questions among the participants. We prepare documentation that answers each question in detail, and then we send that out and distribute it. So hopefully that'll work. We know there's a lot of questions surrounding plan data feed, but as Jason is mentioning, in the interest of time, we're going to move on to our next topic. We will follow up on all these plan data feed questions. And like I said, I'm involved in this pretty directly. So I will do my best to communicate with you about any plan data feed items, questions, etc., that come up. Thanks, Jason. That was a great presentation. And I want to acknowledge Jason has spearheaded and done a tremendous amount of work in developing this. I can't give him enough kudos for everything that he's done.
Thanks, Jeff.
No problem. So again, for the sake of time, we are going to move on to Debbie Dixon's Encounter Data Improvement Project. She's got an update. So why don't we go ahead? Deb, are you ready? I'm hoping Deb.
Can you hear me?
Yes, we can. Thank you. Yeah, Deb,
I'm
ready. Anytime you're ready. Yeah.
Okay. I'm having weird audio issues. I didn't hear any of what Jason said, but I can hear you. It's really weird.
Okay,
so
well,
as long as you can hear me, that's good.
Yep. And
okay, let's go on to the next slide. I know we're kind of short on time, so we'll just skip through some of this.
Do your best.
All right, so basically we all know that we need accurate and complete data for a variety of reasons, not just because it's contractually required, but we use it for various business purposes, population health management, reporting, monitoring outcomes, rate development, et cetera, et cetera. So this update is to talk a little bit about the improvement program for providers to help identify and fix the issues they're having. Next slide.
Oh, there we go. Sorry.
Okay, so this Encounter Data Improvement Program.
There we go. Sorry, twitchy fingers.
The joys of technology.
Yep.
Okay, so we've got the Encounter Data Improvement Program is a part of the larger Encounter Data Quality Initiative. So this is, as you can see here, we've put a team together. We've increased our engagement with plans. As you know, we've been doing these, I want to say we've been doing the monthly webinars for probably a couple of years now. We are working on the quality measures for Encounter Data. The QMed 2.0 report is in the works as we speak, but today's focus is going to be on the Encounter Data Improvement Program that will connect providers with technical vendors to help address their persistent data quality issues. Next slide. Okay, so the idea is the goal is for us to support the plans in identifying who the providers are that are in need of fixing data quality issues and connect them with some technical vendors. So the objectives are to promote some collaboration between us and plans and providers, get everybody involved, because as we know, as simple as it sounds, you have a member that gets a service that goes from the provider to the plan, from the plan to DHCS, from DHCS to our federal partner CMS, and along the way things can happen with that data. So we want to identify what those issues are and where they are and fix those so that we can get some accurate and complete data to our federal partners and we don't lose our federal funding. We're going to monitor those efforts and then share the lessons learned through this forum as well. All right, next slide. So here's the meat of it. We'll distribute about $6.8 million in funding to technical vendors to support the targeted providers. We did not get as much funding as we were hoping from our federal partners, so we did have to redesign the program, and it's a two-phased approach. First, there's an issue analysis, so those folks will take a look at what their issues are and figure out the root causes, and to make the most of the funding, we're targeting a group of providers with the issues that many experience. We want to get the most bang for the buck, as they say, and make sure that we find those issues that affect many providers and many plans so that one fix would actually make a difference in the encounter data that's being submitted. So each plan will identify and refer a limited number of providers to participate, and then we will select those based on some targeted provider criteria. The award amount is still TBD, so to speak, because we are looking at just the limited amount that we have. So that's going to be based on participation and needs that are found. So the second phase is the actual issue resolution. So whatever it is that the folks find when they do their issue analysis, They'll identify the implementation and of the solution to those things, such as maybe just developing standard operating procedures. It could be staff training, it could be coordinating with other payers, it could be reconfiguring their systems, whatever it is that's necessary to actually fix the issue so it doesn't recur. Next slide. So here you can see the priority provider types. As I mentioned, we want to get the most out of that funding that we have. So we are targeting the list that you see here: hospitals, FQHCs, IPAs, county and community-based providers, those that have the most cross-cutting and the highest volume to get the most use out of the funds that we have. So we will prioritize providers based on high volume of Medi-Cal patients, those that are in shortage areas or underserved areas, nonprofit safety net providers, those providers contracted with multiple plans. Again, we want to get as much as we can with that funding and get as much accomplished and as possible. And one of the most important parts is any providers that have not received state, federal, or managed care plan funding are also eligible for this program. There have been other efforts in the past few years to do some encounter data improvement, and some plans and providers may have already participated, so they would be excluded from this effort at this time. Okay, next slide. So the role of managed care plans at this point, what can you do is identify the providers that have the persistent reporting and encounter data issues, review their applications and sign the letters of support, showing us that you agree with what they have found and that you are supporting the efforts that to fix these reporting and encounter data issues. Review the standard deliverables, including the issue resolution plan, give them some feedback and input on what they have determined are the issues and what will fix them, and then confirm that the providers have successfully resolved the encounter data reporting issues. So I think that's a big part of this. We're trying to close the loop, if you will, and fix these issues so that we don't see them anymore. In order to do that, we've got to close that loop by looking at and confirming that whatever that issue was that needed to be resolved, their issue resolution will actually fix that issue so that accurate data will be coming from the providers to the plans to DHCS. Next slide. So here we are as of today. We anticipate the approval from our federal partners. They've approved the concept. We had to redesign the program because we didn't get as much funding as we were hoping. So that redesign is going back in front of CMS. They've got 60 days anytime a funding request comes to them to approve it. It's on its way to them imminently. So we're assuming since if they take the full 60 days, they'll have the end of January to approve it. So that's when we think this is going to happen. Last month, we talked about the website launch. We have that dedicated managed care hub that will also implement at about the same time. That hub was going to provide resources, links, information, all of the things that plans would need to help them with this improvement program and to support providers in correcting all of their encounter data issues. So then in January, we'll also have the plans identify and refer the providers to us. And then we'll also provide some webinars and office hours for the plans and providers to get into more detail about the program. So as questions may come up and to get through all the details and the guidance that's needed so plans and providers will know what to do. And then from March through May will be the application period, and the initial awards we anticipate would be in May of 2026. So this, of course, is all dependent on waiting for the approval of the funding to kick off the program. So obviously it's subject to change, but as of today, this is what we're looking at. So from January to May is when this program will be fleshed out and the providers will be identified, and the issue resolution documents and all the guidance and such that's necessary would be provided in order for the awards to be implemented in May of 2026. Next slide. So what can you do now? I think it's been a couple of months now where we asked the providers, we did a request for information. So we've given the plans a heads up that this was coming. We were hoping to get approval and make this a formal program. So we needed them take a look and identify the potential providers in their areas based on this targeted provider criteria. You'll have a copy of this presentation, so you'll be able to look at that and get a little more detailed with what you're needing to provide in what areas. Obviously, stay tuned for some future communication in early 2026. That's going to include all the necessary detail for this program. This is really more of a heads up so you can get an early start and be thinking about the providers you'd want to include in this program. The guidance document, webinars, office hours, all of that will take place in early 2026. And after looking at this and listening to this presentation and looking at the slides, if you have any questions at this point, then you can just send them to the data quality email box that you see here. Again, the program details are subject to change, but it's pretty well, not set in stone, but the concept has been approved. So it's just a matter of determining at this point what the needs are and how we move forward, how many people are going to participate, then we can get into the details of the award amounts and such. But for now, the concept's been approved and this is moving forward. All right. I know we're getting really close to time, but I think that.
Let's see. Yep.
Is that the last one?
It.
Yep. That was the last one.
Yeah. So, considering time, do you want to take any questions right now? Should we follow up documentation wise? Do you have a choice? Deb.
Yeah, typically, we do follow up.
Yeah.
Because we want to be able to document also for our own purposes, especially for planning and such. We do take the questions in writing and then we respond in writing. That website will be kicked off in, I see one about the website URL, that will be kicked off in January. But yes, same thing. Any questions that you have, please put them in the chat because we do want to make sure that we handle that and we'll respond to each of those and post those.
Sounds good. All right. Here's a preview. Happy holidays. Have a good Thanksgiving, everybody. We are not going to hold a webinar in December since it kind of coincides with the holiday. So our next meeting will be in January 28th. Same time, same bat place, 10 a.m. to 11 a.m. Any questions about the webinar, things like that, please send them to mcdss@dhcs.ca.gov. And although I couldn't see it, looks like there was a good conversation going on in the chat. I look forward to pitching in and helping answer some of the questions and addressing some of the issues. So once again, thank you, everybody. And that does it for now. We will see you soon. Yes, go ahead.
Just real quick, I will mention I'm going through the chat now and providing responses to some of the questions.
Yeah.
I have not necessarily gotten to all of them.
Okay, I could see that going on. And generally we include those because they're recorded. We include those in the documentation that we send out after the as part of the follow-up. So thanks, that's great. Actually, we're getting close to time. Jason, I can keep the meeting open for a minute or two.
No, I wanted to let you know I was doing that. We can do it offline and send the rest out.
Okay. I can see the chat now. As I'm sure many of you have experienced, every meeting software is a little different, so I was hesitant to touch too many controls and throw the whole thing into chaos. Thanks again for your patience, your attention, your input. We'll talk to you in January. Have a great holiday. And as stated, follow up on the questions and other input will go out very soon. So thanks, everybody. Take care.
Thank you for leading it, Jeff. Good job.
My pleasure. Bye.